brought up a very important point, and Dr. Chavez just brought up the same point, which is management of CRS. And Dr. Chavez brought up the point that potentially patients could be treated in the academic center and go to the community. But my concern is this: that still results in a significant number of patients not getting these therapies. There are a lot of patients where that creates an additional barrier. And so maybe as you begin to educate people on this, maybe that's an initial strategy. But I personally believe that making sure that maybe not every place in this world, but most community practitioners should be able to give a therapy that results in grade one, of the 50%, CRS that is reported, the majority of that is grade one. And there are really no grade threes, and grade two is probably maybe another 10% of those. And grade two means the patient needed a little bit of oxygen or IV fluids. So what do you think about the idea that instead of insisting that we should start everyone, quote unquote, at an academic center and then finish it up at home, that we really should encourage community practitioners to be able to do this at home? What do you think? What are you guys doing in your place?
Ruemu, I completely agree with you that, first of all, something you said before, that follicular lymphoma is the disease of community oncologists, because community oncologists are, 80, 90% of the oncologists in America. So why should these patients have to drive extra hours, wait extra parking, because the parking outside of an academic center is much worse? They have to go through the hassle, and or if they already have a relationship with their community oncologist, they should be able to stick with the community oncologist. And this space of follicular lymphoma is the easy space of where bispecifics can get incorporated. So just to clarify, for the FDA-approved DLBCL bispecifics, there is a hospitalization 1 day usually required. For the low grade, for the follicular lymphoma FDA approvals, no hospitalization required, 0. People might be hospitalized, we can be hospitalized, but they don't have to be hospitalized. So that's critical, because I know that that is a huge obstacle for our community oncology buddies, just getting that hospital bed. So I'm not saying that, a 99-year-old patient with high comorbidities might not do better in a hospital. That's possible, but not every patient needs to be hospitalized. Your 50-year-old marathon running patients do not need to be hospitalized for the follicular bispecific antibodies. DLBCL, different story. Follicular do not need, by the FDA label, to be hospitalized. So mostly they shouldn't be. And then the key tricks is, as you were saying, Ruemu, is the optimal prophylaxis to prevent high-grade CRS. Again, lots of grade 1, little grade 2, and people could get grade 3. It's just extremely rare with follicular in the setting. So the optimal prevention prophylaxis against high-grade CRS is optimal steroid use, so dexamethasone instead of prednisone or something else. We've written this all up. It's on the website. We've written, white papers about this. Dexamethasone instead of other steroids. Probably the most important thing is aggressive fluid hydration. So if it's one of these patients that you trust them to be drinking 2 liters of fluids beforehand, great. If they can get the Gatorade or the water in, great. If you can't trust them, they might need some IV fluids just to make sure they are juicy and plump, so that they do not get hypotension. They don't move their grade 1 CRS to a grade 2 CRS. So that is critical. And then it's all about their social support, structure. If they have, good social support at home, we can feel very confident. If they get a little fever, the spouse or the sibling or whomever can give them the Tylenol, Motrin, and more fluids without a big hassle, just like they do for, any old fever that they get from other causes. So I think those are the most important things about preventing high-grade CRS, optimizing the steroid, the fluid hydration, and the social support system. And if you have someone that can't get the hydration for whatever reason, they're not taking their steroids because they're not always complying with their therapies, and they have no social support system, maybe that rare patient should go to the academic or get the hospitalization for that first high dose of epcoritamab. In this case, it's the third or fourth dose. Now, one last thing I'll mention about epcoritamab, difference between follicular and DLBCL. In follicular, we have this triple step-up approval where it goes 0.16, 0.8, 3 milligrams, and then 48 milligrams. That 3 milligram step-up dose is different than DLBCL. So the slower step-ups, we're giving them all kind of toddler step-ups instead of, grown-up steps. Is also the way we have for follicular lymphoma decrease the risk of high-grade CRS. So that preventing of high-grade CRS should make a community oncologist comfortable with follicular lymphoma bispecific antibodies, even though the DLBCL still require this hospitalization. This is the easy place to get comfortable with it in the setting of follicular lymphoma. And eventually these patients are going to want to get immunotherapy instead of chemo. So, you got to get comfortable with it because it's the best thing for the patient. And also it's going to be what the patient will want when they start to realize, oh, immunotherapy instead of chemo, that's a great option. So get comfortable with it because this is the easiest space to get comfortable.
Great. So since we're talking about these adverse reactions, ICANS are infrequent and really very uncommon, but I don't want to completely ignore them. Any words of wisdom on ICANS? I'm going to start with you, Dr. Brody, and then finish up with Dr. Chavez. And then the other thing I want you guys to begin to talk about is how you manage infectious disease prophylaxis.
Sure, I'll say quickly about ICANS. Again, a common side effect with CAR T cells, an extremely rare side effect with bispecifics across the board, and especially rare in these settings of, bispecific antibodies for follicular lymphoma, thank goodness. And I got to say, ICANS is a somewhat mysterious syndrome. It's varying manifestations of an encephalopathy, but if I have a patient who's 80 years old and they get 104-degree fever, they're going to get a little encephalopathic just from having a fever. That's not really supposed to be classified as ICANS, but probably a couple of them do get classified as ICANS. So we don't know optimal therapy or optimal prophylaxis because it's so rare. It's hard to say what's better and what's worse, but probably the things that prophylax against CRS will overlap with the things that would prophylact against ICANS. Again, the most important thing there, I think, are those same prophylactic measures, and even more so the social support system, because ICANS can have different envelopes, different kinetics. But if the family member sees this person is getting a little wacky, a little zonky, okay, now this person might be the rare one that has to go to the emergency room at 7 p.m. because the social support system was there to realize, wait a second, this person is normally super sharp, and now I asked them the month, the day, and the year, and they got the year wrong. Okay, this would be the extremely rare one. So it's about monitoring. And again, that monitoring is, lowbrow stuff. The person is acting different. Maybe it is because of a fever, in which case we treat the fever and see how the mental status is improving with improvement of the fever. But if not, yeah, that's the rare patient that's got to go to the hospital to get evaluated and cared for.
So Dr. Chavez, a couple of words on ICANS, and after that, I want you to tell me what you guys do to prevent. You kind of talked about it, about preventing infections and how IVIG is very important, and I want you to expand more on that, because I think sometimes in the conversation about ICANS and CRS, the more common adverse reaction of infections, especially with continuing therapy where the patients become hypogammaglobulinemic, gets lost and almost gets forgotten. And I'm afraid that patients may not be getting optimal prophylaxis.
Yeah, I think it kind of has to do with the patterns of fever. Usually for bispecific antibodies, the time to onset of CRS is early. So maybe 1 or 2 days, maybe 3 days. Infections, especially with bispecific antibodies, is more like a little bit of a late event. Maybe after even a month or 2 months, or even on the, during the maintenance part, which is 6 months and plus. And the reason is that with CAR T-cell therapy, in addition to the CAR, patients receive conditioning chemotherapy that can lead to cytopenias, febrile neutropenia, severe neutropenia. And then in that case, when we see CRS or fevers with CAR T, we are a little more aggressive doing the ID workup. For bispecifics, I don't think that's my sense, because many of these patients, counts are usually stable. We have the few patients that, especially coming from CAR T, after CAR T, they have some cytopenias, but I usually don't see a lot of cytopenias with bispecific antibodies. In terms of ICANS particularly, I know even for CAR T, there is any effective preventive measure actually. Suma C or the cohort 6 or Suma 1 show that maybe prophylactic steroids may relieve a little the ICANS, grade 3 ICANS, but it's not completely understood. We still don't know what is best to prevent ICANS. I think it has to do more with patient characteristics, tumor characteristics. You have high tumor burden, you have patients with poor performance status, those patients who receive like a CD28 CAR, those are the ones who probably develop more neurotox. I don't think that's a real problem for bispecific antibodies. As Josh mentioned, usually you can see a little bit of neurological symptoms just by having a 102 or 103 of temperature, some type of delirium that may be actually confused with ICANS. And this is actually described in the treatment, in the guidelines for cytokine release syndrome. There is CRS with neurotoxicity and neurotoxicity without CRS. That's the truly ICANS that we say. So, and in terms of infections, I think I'll kind of individualize patients. So if it's a patient, and to me, it's important whether the patient has been exposed to CAR-T or not. If they were exposed to CAR-T, I'm a little bit more aggressive monitoring for infections. I even monitor for CD4 counts, actually. If the CD4 are low, less than 200, actually, I do prophylactic against pneumocystis, Girovesi. But in patients who haven't been exposed to CAR-T cell therapy, I'm probably less aggressive monitoring CD4. I do monitor for immunoglobulin for all patients because eventually those patients have prolonged B-cell aplasia because of the constant exposure to a bispecific antibody. And I don't do prophylactic IVIG. I do treatment with IVIG on patients who develop infections, especially upper respiratory or respiratory infections.
So we talked a lot about the adverse reactions, and appropriately, because I think that has been a barrier to uptake. But I want us to go back and sort of finish this session, especially talking about epcoritamab and lenalidomide Rituxan, about the efficacy. And you both stated high efficacy results, high response rates, almost at 100%, majority of which are complete responses. I just want you guys to sort of finish this section by talking about how robust these responses are and how excited you guys are, including some of those patients achieving MRD negativity.
This, I think, probably may be the future of frontline or second line follicular lymphoma therapy. Today, chemo is a standard. Some patients get rituximab monotherapy. It's not unreasonable. Problem about rituximab monotherapy is it's gentle, well tolerated, but it's just barely kicking the can down the road. You're going to get remissions in some patients, but they're going to be brief. So, in 6 months from now or 12 months from now, you're going to have the same conversation. So not very gratifying to patients. And then they start to sometimes, I think, when they get ineffective therapies, by ineffective, I mean not with long-lasting remissions, they start to get a little, skeptical about the whole thing, and also a little bit, treatment exhausted, emotionally tired of having to hear about a treatment then and not working as well as we'd hoped. So, I think that the future is going to be getting patients these non-chemo-based, highly potent combinations like R² plus epcoritamab, which, I think is going to give patients years of remission. R², has been compared head to head with our chemo, and on its own gives, 3+ years of remission on average. I think when we add epcoritamab to that, which is, one of the most potent single agent therapies for follicular lymphoma ever discovered, when we add epcoritamab to that R², I think patients are going to be getting very long-lasting remissions. And the patients that we've treated on trial, again, as you said, Ruemu, objective responses above 90% and complete remissions in the great majority of people. I think the question is, how long are these remissions going to be? And our, anecdotal experience and the little bit of statistical data we have from aggregate studies, both frontline follicular lymphoma and second-line follicular lymphoma, is years and years of remission. So I think that will be very gratifying for patients when they can keep coming back every 6 and 12 months and still be in remission. And quite honestly, we still are calling this an incurable disease, follicular lymphoma, but that's only because we haven't followed these patients getting, highly effective therapies for long enough yet. Once we're 10 years out from these R² plus epcoritamab trials, I think it is very likely we'll have patients still in durable remissions at some people we're going to have to, at some point, we're going to have to start calling this a curable disease and giving those combination therapies most likely to give cure. And that's these gentle, well-tolerated things that have very high complete remission rates with good durability of response so far.
And Dr. Chavez, what do you?
Yeah, I totally agree with Josh. I think the combination. I think the best place for bispecific antibodies, particularly epcoritamab, is combination therapies, not only for follicular, but also for diffuse large B-cell lymphoma. Very high efficacy when you combine. And I think that's something that CAR T-cell therapy has had hard time to find a kind of like a very good partner. But quickly, bispecific antibodies were able to show the combination is the way to go. And earlier treatment, I think the landscape is changing now in a way that, personally, I'm trying to give less chemotherapy to patients because I know that the bispecific antibody, especially in combination, may be a better treatment option for patients. And I agree with Dr. Josh Brody that, there is high CR rates and also high MRD negative rates, which actually can lead to prolonged remission. So I'm kind of trying to move away from chemotherapy as much as I can, knowing that, we have these options and knowing what chemotherapy can do to patients, especially patients who have been on several lines of treatment. So I think the landscape is changing now based on what we've seen with bispecific antibodies in follicular.